Hello and welcome. My name is Jamie Singletary, and I am the Director of Family and Alumni Programming. And I have the honor of introducing our next speaker, who is going to be Dr. Wendy Oliver-Pyatt. And Dr. Pyatt is going to be talking to us today about the perfect storm, intersection of pandemic trauma, eating disorders, and the mental health crisis. During this presentation, Dr. Pyatt encourages you to utilize the chat feature to ask questions. She wants this to be conversational. She wants you to be able to share your feedback, your comments, your concerns. So we will periodically be looking at your questions to make sure that they are answered. Please don't forget to check your CEO dashboard. The dashboard is going to provide the survey for this presentation, along with the link for you to download your certificate. So without further ado, I'm happy to turn it over to Wendy Oliver-Pyatt.
Thank you, Jamie. I appreciate you so much. Thanks to everybody who's here today and being a part of the Within Health Summit. You have to sort of pinch me to make me realize that this is all happening. The summit was put together, a labor of love and the vision of some really creative forces that we wanted to bring together: media, academia, social media, and just really kind of look at eating disorders and mental health in a greater context, and making sure we're not only just like preaching to the choir, if you will. During the pandemic, I had time, to just kind of roll around in a lot of different ideas. And one of the things that I've become very, very interested in is epigenetics, and also trauma and intergenerational trauma. And that's both due to just the number of people that I've worked with over the years who have trauma. It's said that about 80% of people going into eating disorders needing higher level of care have trauma, as most clinicians who've worked in higher level of care, most clinicians who treat eating disorders certainly know that. So for those professional reasons, I've been very interested and wanted to learn more and more and more. And today's talk also has a very special to me and personal kind of history to it, because I never really used to talk about this in the field, but I began sharing this a little bit over the years, just not a lot, but just a little bit, is that I'm the child of a Holocaust survivor. And so that has really impacted me and influenced me. And so the whole intergenerational trauma began to make more sense to me as I was learning about it. And then when we had the pandemic and the crisis, the mental health crisis, and at the same time, we had a major amount of racial discord. We had the George Floyd trauma, which was a social trauma for an entire country. It made sense to me that we needed to do a talk that tried to kind of bring this all together in some kind of framework. And I do have a 3-hour version of this talk as well that goes into things more in a more detailed way. So if you do want to ask questions along the way, I would love to do that, because part of this isn't necessarily like going to inform how to treat a specific patient, but I think it does have applicability to our patients. But it's also just deepen our understanding of the importance of thinking about the whole system that the patient is living within, not just their immediate family, but intergenerationally as well. So we're going to talk about all of these different areas here. We will not be doing the chant at the end, but I'll have our colleagues send out the chant that I want to share. Chanting is just a beautiful way that inspires healing. We might be able to do the chant at the end of the summit tomorrow, but so this is kind of like what we'll be doing throughout the talk today. So I developed this slide to just kind of put a graphic together of like what is the perfect storm. So if you think about intergenerational or transgenerational trauma, social media, the pandemic, and diet culture is like, wow, that's what the word came to mind. What a perfect storm. And I think that the piece I really want to kind of like roll around in a little bit is that folks that sort of came into the pandemic with that background or that epigenetic risk, not necessarily that they themselves had gone through trauma, but if they had that epigenetic risk, they were really primed for potential psychiatric, manifestations of the pandemic, which I think we saw, those changes in people and the long wait list to get into programs. And I think that, and we'll talk about it through the talk, the social media is also connected to this onslaught of mental health. Certainly social media and diet culture is interconnected significantly. And one of the themes that one of the mantras that I'm starting to kind of try to say and get repeated, and I think we need to think about this socially, is that with social media should come social responsibility. And we really don't have those two. It's social media is over here. Social responsibility is in like nowheresville. I mean, we do have some people who are stepping up to the plate, like Pinta Chris that they presented yesterday. So there are some organizations that are stepping up, but it's different. Television was really monitored, but social media doesn't have guidelines. So it really is pretty rogue what's out there. And it's important to really think about these things really affect our brain. And especially if we're vulnerable in some way, shape, for some reason or another, in some way, shape, or form. This is just a very brief summary of just some of the changes that we see post-pandemic. So pre and post, you see 4 and 10 that became, developed symptoms of anxiety and depression. 4 out of 10. It's almost half of our population, where it was more of like 1 in 10 before. I mean, 4 out of 10 is a lot. That's a lot of people struggling with anxiety and depression. It also says a lot. I think it should say a lot about our society as a whole, and what kind of culture has been created in our society and how that's affecting all of us. Some of the other important findings were we all saw the struggles around eating disorders and disordered eating. We saw exacerbation of chronic conditions. Also, people were not getting the care that they needed, and people weren't, I think in general, when you're depressed and anxious, you have a tendency to not take quite as good care of yourself. Certainly insomnia, and then also alcohol consumption. There's another piece to the social media story that does not really get a lot of attention, and that's traumatic events online. I am really upset by traumatic events online, because I think, especially for younger and younger folks who are really, it's very normative for them to be with a phone at all times. I mean, I'm of the generation, I don't think I had my first iPhone. I don't remember when I first could use text messaging, but it was, later into my adult life. But we have kids that are accessing these traumatic events online from very, very early in their development. And I just think that these images have an effect on us. And certainly certain populations are going to be more vulnerable to the effects of traumatic events online. Now, what seems to happen is that if a person is aligned with the person who is the victim of the traumatic event, or of the same immigration status, it seems to have more of an impact. So this is a study that was a multiple regression analysis by 302 African American and Latinx youth. More frequent viewing of traumatic events online is associated with increased PTSD and depressive symptoms. And I don't think we're taking this seriously as a society at all. And I think of it in a way that I think of diet culture. And when I was young, it was your mind on drugs, just say no to drugs. Like there was a real kind of emphasis to do psychoeducation with younger folks about the gateway drugs and all of that. So we learned a lot about that. When it comes to eating disorder and diet culture, it really hasn't become normative through our governmental agencies or our schools or our systems to really be talking about the importance of educating about diet culture and thinking of dieting as a I think of dieting as a gateway behavior. So for me, because of my background, personal and professional, of course, I was very forceful with my kids, forceful in a loving way, but very outward. I think about really my kids thought of dieting as like, oh, that's this horrible thing. And it's this thing that you do if you're being oppressed, and it's a part of an oppression in general. So there was a lot of talk in my family around that. And I think we need to create more of that. But I also think that when it comes to traumatic events online and the access that young folks have to traumatic events online, is that we've gotten just very lackadaisical about it. And kids are experiencing this in profound ways. And so I think that this is something we need to really be more vocal about with our kids and with our patients, the access to the phone and the access to what is just completely dehumanizing, horrifying experiences, and the importance of understanding that if it's one owns racial or ethnic group, those folks viewing that are going to be more vulnerable to watching these traumatic events online. I could go on and on about this, but I think I better keep going. So the phone really is a social environment, right? It's in our pocket. And before the phone, if I'm in my living room, it's just me, myself, and I in my living room. With my phone, I can access the planet, and the planet can access me. So what's so tough about that is that human beings are really not, sort of, if you will, hardwired to have access to so much incoming data. We're more designed to have a social structure containing about 150 individuals in our sort of immediate daily life. And then what happens is that with social media and things like Instagram, likes and things of that nature, there's also an addictive piece of it, because these kind of interactions with the phone create what we call intermittent reinforcement. So intermittent reinforcement is the kind of reinforcement that is most likely to cause addictive behavior. It's the kind of pattern where one doesn't know whether they're going to get the reward or not. Gambling is really, slot machines are like a very good example of it. So you keep pulling that lever down because you might hit the jackpot, or you don't hit the jackpot for a while, but ring, 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 all of a sudden here comes the money. So it's that intermittent reinforcement. That's what happens with social media, with likes and Instagram and all this stuff is like really coming in. And I think that, depending on the vulnerability of the person, it's not just their age. They're much more potentially going to be potentially affected by this. And this is coming into the psyche of vulnerable people 24/7. There really is something called smartphone addiction. And I've actually talked to a psychiatrist who has a program in Texas that treats smartphone addiction. And he's worked with a couple of these young folks that have done mass killings. And he has said that literally that some of the kids, some of the games that they're involved with too, their brain really actually does actually change, and they're in almost an altered state of consciousness. Certainly when you're on the phone, right? You're doing, that's a brain activity, right? There's things that are actually happening in your brain as you're sitting there on the phone day in and day out. We forget about that, but we're actually changing and lowering gray matter volume in insula and temporal cortex. We're actually reducing resting state activity of the anterior cingulate cortex. So the anterior cingulate cortex volume and activity is associated with the addiction severity. So I know myself, I feel anxious if I misplace my phone. So there's something physiological going on when we're on the phone. There's another variable at play. Shoshana Zuboff from the Harvard Business School coined a phrase that I want to share with everybody that I was fascinated by, and it's called surveillance capitalism. What surveillance capitalism is, it's tied in a little bit with these the paradigms within the different social media forces, if you will, that interplay with our choices and create advertising and marketing that's like very designed specifically to the specific individual. So in the past, marketing was more done like where we put an advertisement on the TV. It's sort of like going out to everybody, the masses, and the more people see it, the better as far as what marketing was concerned, right? This kind of this what we call surveillance capitalism is really this very specific kind of targeting of who we are, adults and children alike, that allows marketing to come at us in a very specific way. And it can be very, very reinforcing. So this is something that's also at play with us when we're on our smartphones and in social media. So this is just a little graphic that kind of shows how the problematic internet usage can sort of also feed into the development of issues with self-care, lack of routine, certainly hypervigilance related to body. I mean, I've talked to patients who got onto some of the websites that have to do with plastic surgery, and just their brains get sort of like locked into this. So we'll just keep going along. Another piece of this that's all connected, into the perfect storm, I want to share the concept of adversive childhood experiences. I'm not sure how many of you in the audience know what that is, but it is tied in also with epigenetic modifications. So witnessing violence, childhood abuse or neglect, racism, these are all adversive childhood experiences that cause epigenetic changes. So if I'm somebody who's experienced adversive childhood experiences, right, I may not necessarily manifest those symptoms, but I'm making epigenetic modifications that I make are getting passed on to my kids. I certainly am also becoming more vulnerable. So there's real actual changes happening in our brain when we experience adversive childhood experiences. So epigenetics versus Darwinian genetics. Let's talk about that for just a minute. It's really, really interesting stuff. So funny story. I was a biology psychology major at University of Denver a long time ago. And my daughter was in 9th grade at the time. I think it was 2010. She was in her biology class and they were teaching her about epigenetics, and she was having a hard time understanding something. And she showed me her textbook and they were talking about epigenetics. I was stunned. That was the first time I ever heard about epigenetics, because, and this shows you how science changes. When I was in college studying biology, we were trained about Darwinian genetics as if it was like gospel. And it was like, it was like survival of the fittest, and the DNA does these little changes, and that's correlated to adaptation and survival. And the changes really just in Darwinian evolution, changes happen very, very slowly. It's just little amino acids changing the DNA strand itself that over time turns into modifications of what we call the phenotype, the way the person physically is, mentally and physically all linked together. So epigenetics actually happens really fast, though it's not changing the DNA. The DNA is deoxyribonucleic acid. It's got a long chain of amino acids. It's not changing the DNA itself. It's just changing certain features of the DNA, where there's methylation of endocrine genes, reduced methylation of inflammatory genes, and increased methylation of serotonergic genes. So we've all heard about the endocrine system, the inflammatory system, and the serotonergic system when we've worked in mental health, right? So yes, these are all genes that are tied to mental health struggles. And so these epigenetic modifications are actually correlated with health disparities, as described and seen on this slide. For me, that was a very big deal in 2010 to discover there was something called epigenetics. It also, again, shows that science feels like hard science in the moment. People believe it because it's all we have in the moment, but science is always changing too. That ties into also just, the concept of evidence-based treatment. Just because we don't have evidence for something doesn't mean that it necessarily isn't impactful, because science is, we can only study what we know to study, or what we have the capacity to study. We now understand epigenetics in a way that we didn't back in the 1980s when I was getting my degree. So the brain and the rest of the body are very interconnected. And so as these aversive childhood experiences are happening, it really can overload the biological systems. And I think that when we think about the pandemic, again, there was the perfect storm. Here are all of our kids, some of them with already risk factors, of course. They've also, on top of the pandemic, they've got a phone with them the whole time. They're isolated from their peers. They've got a phone with them all the time. They've got diet culture coming at them. I mean, it's the perfect storm. And that's how it goes from 1 in 10 to 4 in 10. The brain, when it gets overloaded, it changes. There's a real manifestation of changes to the brain circuits related to the stress. And a lot of the changes that are epigenetic changes seem to be tied in with both the immune system and also inflammatory system, which can also, as you probably know, can affect the cardiometabolic system as well, and the endocrine system. So there are, it's okay. Yes, we do have to have some kind of stress in our life, right? Stress can be a part of our growth, as we all know. I mean, that's what we're stressing our patients in many ways, right? That's how we grow. I mean, certainly giving talks is a little bit of a stressor, but it also makes me grow. So there's positive stress, there's tolerable stress, and then there's just absolute toxic stress. So this is really where the brain architecture actually changes. I don't know how many of you have actually seen the ACE pyramid, but I just wanted to share it for the sake of this, to be full within the talk, is how the aversive childhood experiences affect neurodevelopment, which affects social, emotional, cognitive. Now we're into health, risk, behaviors, disease, social problems, and early death. This is an actual slide of the brain going through this architect changes. So the brain is supposed to go through a normal type of pruning, but through these aversive child effects, we're not, the patient's brain is actually not changing in ways that it needs to. I'm super happy, not happy that this happens, but I'm happy that we're expanding our understanding of trauma. So when I was coming into the field, there was PTSD, and you had to look at those specific traumatic events, and there was a certain way that had to be described. And then if you didn't have that, well, you couldn't have PTSD. But we all knew there was more to it. So now we have CPTSD, which really, really helps us put a framework around what our patients are going through. Something that I'm very, very moved by is our capacity in a remote setting to actually work with some of this trauma. I think there was a presentation earlier on these very creative and innovative ways that we are doing that, because you can't leave trauma off to the side. There used to be an era in the eating disorder field. Some of you old timers probably know that the insurance companies didn't allow us to, we weren't supposed to deal with the trauma. We were supposed to just focus on the eating disorder. You can't talk about the trauma. You shouldn't treat the trauma. The patient's going to get worse. So patients came to higher levels of care, and the insurance companies told us not to treat the trauma. So not only do we now sort of have permission from the insurance companies to treat the trauma, thanks to a lot of the research that was done by people like Tim Brewerton, who was really ahead of the game. I applaud him. Actually, I interviewed him for another talk. He really did a lot to change the field. But so we know that, we know it's okay. The insurance companies say it's okay. We have a much deeper understanding of all these things that can count as trauma. And we have a lot more ways to actually treat the trauma. And we kind of know with trauma that it's going to be a little different. It's going to unfold in more I find that treating trauma is very meaningful to me personally, and it sort of unfolds in a less predictable way. But when you are able to kind of get under there and support the person in ways that really give them added stability, it's a really meaningful step for them in their healing journey. So this slide just really kind of points out the whole piece about CPTSD. And I've added things since I first made this slide many years ago. I made the slide prior to the pandemic. So now, of course, I've added things like racism that's much more openly, people are much more openly aware of the existence of racism. There was I think a little bit of a Pollyanna period, but I think now we're a little bit more aware because of social media that that's the plus side. People, you can dig your head in the sand only so far. Traumatic events online are very tied into some of that as well. Political divide, we've never had this kind of political divide in our country. And then just the things that we also have known about for a long time, like invalidating environments, diet culture. Certainly weight stigma is now recognized more and more as a form of trauma. Back in the day when we started the Binge Eating Disorder Association, we created the Weight Stigma Awareness Week because weight stigma is a part of every form of eating disorders, and it's a part of our day-to-day life. And it is really traumatic for many people who are the unfortunate and traumatically affected victims of weight stigma. And we have to do better as a society, much better in that regard. So trauma is just such a overwhelming impact on the body, on the mind. And again, I'm probably preaching to the choir here, but I think that of all the things, they're all of these are very important, but I think as it relates into food, some of the things that we really have to pay attention to is the loss of trust. We have to pay attention to shame, loss of physical connection to the body, dissociation. All of this stuff comes into the eating disorder work. This is just a little kind of demonstration, I guess, of a way that I sort of see the eating disorder manifestation of the trauma. So trauma has associated with it avoidance, right? We do know how that avoidance manifests. If you're just thinking about PTSD, numbing, kind of feeling like you don't care about things, lack of interest in activities, that sort of just non-enjoyment of life. So anhedonia type of stuff. So avoidance in eating disorders, it can be restriction of emotion, restriction of eating. That can be all forms. Restricting anorexia is not just for anorexia. People with binge eating disorder do a lot of restricting as well. The I'm fine mentality, the disconnection from food, the disconnection from appetite and hunger, and the disconnection from the source of life, which is food. And I think there's a dynamic interplay there between trauma, avoidance, and disconnection from the source of life. Then there's arousal as a trauma symptom, which is the exaggerated response to startle, the hypervigilance, irritability, outburst, sleeping difficulty. Well, in eating disorders, you see that arousal as well. I call it the faulty alarm system in eating disorders, where there's an exaggerated response to things like eating a peanut butter and jelly sandwich. The body, the body's in red alert mode, like feeling extreme danger, right? So a real hyper arousal response that's connected into food. And when you see this, it's important to understand, because what happens in treatment, and this breaks my heart, what happens in treatment is that a person might have these exaggerated reactions to eating into food. And oftentimes the approach around that is merely behavioral. There does need to be containment and behavior containment. People have to kind of be given the support to be able to manage their faulty alarm system. But behavioral containment without a psychodynamic formulation and an understanding of the origin of the arousal, that is really that's gaslighting. And I see this more and more, and it takes such a commitment to a deep level of work with each human being that we're touching in our lives clinically, to be sure that we're doing more than just behavioral containment, that we're going underneath that behavior and delving into the source of the pain and the hurt, and recognizing that the trauma has intergenerational and transgenerational manifestations, which really our patients, some of them have been sort of, set up in a sense to develop their eating disorders, given the epigenetics, given the culture. If genetics loads the gun and environment pull the trigger, the environment's pulling the trigger a lot. So then the relieving is the flashback. And I think just the preoccupation with food and eating, and I think not eating or the food preoccupation, in a sense, it sort of masks other memories. I mean, I remember one of the, I've learned so much just by treating patients, way more than by anything I've ever read in any book or heard at any conference, I think. So just seeing patients who we've worked with, and as we're sort of working on the eating disorder, we're always working from a multidisciplinary approach and always searching for the meaning of the eating disorder, the meaning of the symptom. But in working through some of the behaviors with the food, the unmasking of memories and things of that nature that I've seen happen time and time again, which is actually mind-blowing, but it shows you the importance of digging deep. So that was just sort of a way to think of PTSD and eating disorders, how they sort of are one and the same, but sort of showing up in different ways or different behaviors. So just to be sure, we're circling back now on intergenerational trauma. So we've talked about social media, I've given you some brief understanding about what epigenetics is, even though I'm far from a biologist, and gave you the most basic understanding, which my understanding doesn't go much beyond that, but I do understand like the idea of it. But I wanted to circle back to just really talking about the intergenerational trauma. So this is where I've gotten really fascinated because of our patients and because of my personal story. And I think that a lot that we have read about and think about that relates to the Holocaust dovetails with racism in our society now, that exists now. So there's intergenerational trauma that got a lot of, more attention thinking about the Holocaust, but racism exists right now that is both the byproduct of intergenerational trauma and also perpetuating further intergenerational trauma potentially. So this is just a very simplistic but still important, pause to make sure we're recognizing the impact of racism on child development. Coping with systemic racism and everyday discrimination is a potent activator of the stress response. Again, the stress response. I have my dad is married to a woman who is a white female in her late 80s. Sadly, she just had a terrible fall and she was in a rehab and in Miami. And she was making an observation that she kind of felt like maybe as the white person, not Latin, she kind of thought maybe some of the Latin caretakers sort of preferentially treated the other Latin patients. And she was just aghast by this, like, how could this possibly be? And I just had to bite my tongue because I was thinking, welcome to society for a lot of people who aren't white. And so I think it's just important for us to keep that space in our heart as we're thinking about what people are experiencing on a day-to-day basis, who we're treating, who we're encountering, and just how painful it is, and how difficult it is, and how not resolved this is. And this is digging in early on, the idea that children are having to have this stress response is just like very heartbreaking, really. So I'm sort of linking together racism and the Holocaust because it's sort of more, I think there's more sort of known about intergenerational trauma. When people think of intergenerational trauma, they tend to think of the Holocaust, but I don't think enough thinking about racism in general that exists right now. But I think that what you can gain from thinking about some of the research around the Holocaust, it applies, to all sorts of trauma. And so I'll just share a little bit about that. So the trauma transmission is thought to be psychodynamic, sociocultural, family systems, and biological. The biological is the epigenetics part. So in the psychodynamic plane, there's this idea that the child sort of absorbs the Holocaust experience and their survival parents and become a reservoir for unwanted and troublesome parts of the older generation. The massive psychic trauma shapes the internal representations of reality, becoming an unconscious, organized principle passed on by parents and internalized by children. When I read that, it gave me the chills, because just sharing a little personally here, I felt that created that, those were some words that affected me. I always remember the existence of the Holocaust. I just never remember being told there was a Holocaust. I just knew there had been a Holocaust. I don't know why. And I feel like there was a darkness that was just inside of me. And I don't know how that came to be. And I know it might sound a little cuckoo, but I just felt it. And so I think about racism as well, and the gruesomeness of slavery and the transgenerational trauma there, and how that's manifested forth now. And it's just something I think we have to be really thinking about. It kind of brings us back to the concept of the biopsychosocial model being so important. Sociocultural, don't trust anybody, exaggerated worries, anxious parents, parents really needing their kids to stay very close to home. My dad about had a heart attack when he found out I was going to go to medical school in New York City. Then the family systems. You can see this parents living vicariously through their children, kids sort of having that survivor guilt and feeling like they sort of need to make up for the losses of others. So a lot of things that are happening within family systems. And then the biological, which we already talked about, epigenetics. So I've already made this point. I'm just adding it again. Again, it's the study of how your behaviors environment change the way your genes work. And this is really, again, the genes themselves not changing, just changes to the genes, involving primarily methylation. It's also some histone modification. Oh, and they're reversible. Epigenetic changes are reversible. That's what's really interesting. So in trauma, there's multiple findings that show the heightened immune reaction that are tied into PTSD sufferers, and it's tied in with epigenetic modifications. These are also just some other ways that the Holocaust can manifest, as we were talking about the sort of a biopsychosocial model, that I think tie into all forms of racism. Catastrophic expectancy, preoccupation with death, vicarious sharing of the traumatic Holocaust experience, which sort of dominates the inner world, and annihilation anxiety, nightmares, dysphoric mood, unresolved anger. So this is just my personal experience. I always knew that darkness and that fear that was always kind of lingering around me, that I didn't know where it came from. But I think what kind of came out of that for me was I developed a lot of compassion, but it was also very destabilizing for me. So within that framework of epigenetics, intergenerational trauma, and what's going on, within the family system when there's intergenerational trauma, when you think about socioculturally what was happening during the pandemic, right? It all sort of comes together, because I think a lot of it boils down to, when we're looking at all these like risk factors that for mental health problems, in some ways, these things boil back down to people having needs, and our struggles and our pain, mental pain, is tied in to the fact that we have needs. That's why eating disorder patients are so tough, because there's a denial of the need, the most basic need, to eat. But we all have needs. And the pandemic, the epigenetic changes, the smartphone addiction, diet culture, it's all tying into like we were not able to get our needs met during the pandemic. We were not. And when I had more time for a longer talk, I actually do a breakout room at this time, because I like to give people an opportunity to share, if they're willing, different ways that their needs might not have been getting met during the pandemic, and then maybe also some anecdotal things. But Kaufman, I think, says it best. I freaking love this. I use this like if I want to have the talk end in such a way, like my hope is that by doing this talk, I want to feel like when people leave, they have something to think about that might help them or that might help their patients. Not just talk about trauma and not just talk about epigenetics, but like, really, what am I going to do to help my patients now, or myself or my family, right? So I think if I had to think about anything, I think understanding kind of in general, what are those basic needs that we have, and how do we meet those needs? So the basic needs that we have as humans, according to Kaufman, he's got it nailed. Six basic needs is that we actually have a need to feel loved and wanted, and we feel shame also when we don't have love and feeling wanted. We have a biological need for touching and holding. It helps us feel safe, comfortable, and protected. My daughter reminded me when she had COVID, she said, oh my gosh, I can't see anybody because she had to be in isolation. I can't touch anybody because she was in isolation, and she couldn't taste any food. So she lost 3 of her senses due to the pandemic. Another thing that we need is to be able to identify with a parent in a healthy way. So when this one ties in also with intergenerational trauma. When our parent is affected by trauma, it's very hard to sort of take in that personal culture from the parent and then have your own healthy personal culture. Differentiation is another need that we have. That can be very blurred. The process of different separation and individuation can be very blurred, as we all know in some of our patients, when you're going from more dependent to independent states in a parent that might have their own trauma. We also have a need to nurture, right? We want to receive, but we also want to give. And then affirmation is another need. We don't have our needs met. Kaufman talks about, by not having needs met, we actually, instead of thinking something's wrong in our society or something isn't right within our world, there's a deeper tendency to feel shame around needs. Like, instead of like, oh, my environment couldn't meet my needs, there's this shame around the existence of the needs. I shouldn't need this, is really where the child goes with it, right? So the child takes it the other step, rather than, oh, my family is stress or trauma or whatever. It's, oh, I'm needing these things, but I'm bad for needing this stuff. That's a very common, that's part of just child development too. So again, this is really where we could talk about this. And if we have time, it's about 3:00 now. So we'll have time for a little discussion if people want to talk about how the pandemic and social media has influenced their ability to have their basic needs met, or if you want to talk about anything. I only see one thing in the chat right now. I don't know if that's accurate. So hopefully there'll be some more communication. So now we're like towards the end of the talk, and I'll just share sort of something that I created for myself back when I was in college and I was trying to figure out all this stuff for myself. And I read, and I use this with patients to this day. So I read The Art of Loving by Erich Fromm. And Erich Fromm talks about any kind of art requires concentration, knowledge, respect, and discipline. So that's what he talks about as for any art. So we can sort of take that into the art of healing and the art of living, the art of healing in your relationship with food. And I kind of turned it into a cycle. I was thinking about it. It's like, well, it actually kind of creates a cycle, because the more we concentrate, right, the more mindful we are, the more knowledge we tend to have, the more knowledge about ourselves, our origin, our history, is a deeper sense of who we are, where we came from. Well, guess what? That leads to respect. Understanding and knowing ourselves leads to respect. We develop greater respect for ourselves when we understand why we feel the way we do. And this can lead to shame reduction and compassionate self-awareness, which is something that I am a big believer in and a big fan of. So the more respect we have for ourselves and the more self-awareness we have, compassion we have, the more discipline we have. Again, when he's talking about discipline, by the way, he's talking about Eastern, not Western. Western is discipline is no pain, no gain. No, he was talking about the Eastern definition, which is that we do things because if we didn't, we would miss out. We would feel badly that we want to do these things. So that's like a big piece for healing with eating disorders, especially I think as it ties in specifically with movement. So moving out of the mindset of like burning calories and counting steps and how many minutes were you on the stair machine or whatever, more into that Eastern definition is like, you do these things because they make you feel better. Lately, I've been getting to weightlifting. I like to like feel that physical feeling of like pushing that weight up. And it's something I like. I mean, I've done yoga before and I've done a lot of different things, but it's really getting into yourself and like what feels good within yourself. And I think we just really miss this. I could go on and on about movement and exercise and all that. But really discipline is really around that really ties into self-care. And guess what? The more self-care we have, the more concentration or mindfulness we're going to have. So this is the way I've sort of created this way of healing. And it's really just because I want to leave you as we wind up the presentation with something to, I hope, give you a little something to think about that I'm sure everybody can make their own judgment if it's helpful or their own maybe tweak to it that fits their life or their practice, but give you something to hold on to, because again, we're talking about pandemic and trauma and epigenetics, and it's all very dark, but it's sort of like, well, what are we going to do on the other side? So I think of this as a cycle that we can get going. I also, when I'm giving talks on this, I have people talk about, what's the opposite of this? What's the opposite of concentration? Mindlessness. What's the opposite of knowledge? Ignorance. What's the opposite of respect? What's the opposite of discipline? Because that's where the eating disorder gets in, where we slip off. And we all sort of have different places where we might be more vulnerable to kind of slipping off. Some of patients that I think have eating disorders are very vulnerable around the self-respect piece, and they can slip into shame easily if we're not careful. I want to give a shout out to Joe Kelly. I don't know if he's watching right now. He does a wonderful group at Within Health, which is a male loved one support group. Pointing out, by the way, that we support male loved ones, and also pointing out there are men with eating disorders who need our support. My wonderful co-founder, Abi, made that point recently, and I'm glad he made that point. But his daughters made this wonderful organization called New Moon Girls, which I discovered a long time ago. I ordered it for my kids. Now they have a social media presence, and I want to share it with you because this is a wonderful thing for kids to see, and it's a wonderful thing available on social media, done right by Joe Kelly's family. Here's a little slide about how we can build resiliency around social isolation and traumatic events. This is not rocket science. I will say, though, a couple things. I adapted this myself, and I think finding meaning in suffering is really important. I think that's something that we need to do as therapists, as family members, like help us dig underneath the hood and find the meaning from where we've suffered. I mean, I would never sign up for having an eating disorder. And even to this day, with all that I've quote unquote gained by being able to work with eating disorders and work with amazing humans and have this crazy, wild life experience that I'm having, I'd still prefer to have never had an eating disorder and been on my merry way without that. But I think finding meaning in suffering is important. And I think also exposure and involvement with art is really something that we're not really doing enough of, being creative and being messy. So in tribute to my father and his family, this is my dad's family. who perished in the Holocaust, all but my dad and his sister. My dad is with the older woman on the far left, and his sister Frida is in the back. I'm named after Frida. My middle name is Frida. My name is Wendy Frida Oliver. I used to be very ashamed of my middle name being Frida because where I lived, everybody was Deanna Sue, Marianne, Julianne, Shirley Ann, and I was Wendy Frida. So I felt like a little bit of an oddball, but now I'm so honored to call out my aunt's name. So this is his family, and that's my dad on the left. He's 94 years old. He lives next door to me. And it's really wonderful that I have this understanding of him and intergenerational trauma and epigenetics and how that all comes together. That's my dad and his wife, me, Wendy, the little girl with the apple tree in Carson City, Nevada. Never imagined I'd be doing this today. And then a tribute to my dad, and something that helps him a lot is this wonderful Ralph Waldo Emerson quote. That's probably my favorite quote, period. Oops. Be not the slave of your past. Plunge into the sublime seas, dive deep and swim far, so that you will come back with self-respect, with new power, with an advanced experience that shall explain and overlook the old. So being able to be with you all, being able to be a part of this organization, this creative journey that we're helping others or trying our damnedest to is my advanced experience. I could never thank you all enough for being here and for being interested in what we're doing. And I can never thank the Within team enough. I will never be able to thank the Within team enough for making this possible.
Thank you, Wendy. That was an excellent presentation. We actually do have a few questions from the chat, but they are anonymous, so I do not know who they are from, but they are great questions. The first question is in reference to Joe Kelly, the mention of the Male Loved Ones group. One of our attendees wants to know, is that a group for clients, for family only? How does that group work?
Great. Well, I mean, do you want to talk about that?
I can. I can.
I mean, that's and I would love for you to talk about it. I mean, I can answer, but I'll take credit before she'll answer, but I'll take credit. I've loved Joe Kelly and his work for a long time. And when I called him up and asked him if he could do this, I was so grateful that he was willing to do this. He had a video called Dads and Daughters Journey of the Heart. I must have bought about 8 of those cassettes. Everybody took them and I never got them back. But go ahead, Jamie, if you don't mind answering for folks.
Not at all. I do not mind. So to answer the question, as Wendy mentioned, Joe and I have had the opportunity and I've had the pleasure of co-facilitating a group with him since I've been a part of the Within team. And that group currently is for the male loved ones of our clients. So we are looking at significant others, dads, brothers, anyone in the family, a male loved one in the family that feels like they have been impacted, which at Within we feel like the whole family system has been impacted. So we're very inclusive of including the family. They are able to meet once a week to just process and go over what it is that they are feeling, ask questions, what they need to know. And the group has done very well, I can say that, in terms of having a safe place for gentlemen and for men. And Joe and Rebecca presented yesterday. And we also had Dr. Ziering present yesterday on eating disorders in males. And so what we're doing here Within is creating a space that's very inclusive to everyone that can be impacted by an eating disorder. And so to answer your question, that group is for the male loved ones of our clients right now.
And we do have a multi-family group, and we do individual therapy. We do individual family therapy, and individual coaching also. The coaching is done by the nursing staff primarily. Any other question?
Yes, the other question we had, Wendy, this is in reference to how Within came about. It says, did the idea or motivation for Within come from any specific TEO or COVID related?
Oh, good question. Thank you for asking that. So the funny thing about Within was that It was kind of a lot of things that just came together all at the same time. Again, all that stuff happening like a Venn diagram. So one of the things that had happened is that I had started treating some patients through telehealth. Prior to even the pandemic, for probably a year, I had started just a little private practice. And I was thinking to myself when I was working these patients, well, I'll be darned. Like I was like, well, I'm noticing that these patients, even though I'm not with them in person, like they're getting better. And a few times I've worked with people and thought, if I felt like if I hadn't worked with them, they might have, I felt like if they hadn't accessed care, right? I'm not saying it was me, but if they hadn't accessed good care, they would have ended up, in a higher level of care. So I started to really believe that there was something to that. And I got the idea that I wanted to do some kind of virtual type of treatment that allowed more people to have access, because there's too many people not able to get care, not able to leave for treatment, blah, blah, blah. And then I shared this idea with a gentleman that I've known for a long time, and he actually knew Abhi Patel, my co-founder. And so he knew that Abhi had interest in behavioral health, and he had a lot of marketing ideas and background and experiences, extremely entrepreneurial. He'd started companies, invested in companies, and he just has he's got a great mind. He's just absolutely brilliant. And he has an amazing personal journey as well that he's comfortable talking about. And so when he and I met, and we got to know each other, we just realized that we came from different places, but we had kind of like the same heart for doing the work. And so that was kind of like how it came together when I met Abhi. And like he sort of had an army of people that had so much to offer from all sorts of like the non-clinical side. And then I had so many people from the clinical world and the industry that I could bring in. It was sort of like I guess it was just like a good match. I like to think it's a good match.
And we have time for our last question. And this question says, how has using a virtual platform for care with helping clients with eating disorder been difficult or better than traditional in person or brick and mortar, I think is what they're saying?
Great question. And I love the way it's framed, because what I think is one of the things that I've learned through this process, because it was for me a learning journey. What I've learned is that we tend to have an idea that remote care is like second place to brick and mortar. We have a preconceived idea that's the truth. It's sort of, and that's, I think, because a lot of programs were sort of popped up very haphazardly in the name of the pandemic. And not to discredit that, but I mean, we designed this program to be a program that was on par with a brick and mortar program. That's why we have the app, that's why we have the food delivery and the intensity of the services. I mean, the amount of care that people receive through our program is actually, there's more staff per patient than what you see in a brick and mortar by far, because it takes so much more. The food has to get delivered. We have to make sure the person eats the food, but we're not sitting there, with them. So one thing that's really beneficial about remote care is that the person's doing it in their home, right? They're doing what they need to be doing. They don't have to translate that benefit from a brick and mortar into their home. So I think not having to jump between milieus, from a milieu to your home, and losing the care providers you had when you were getting better, and then being back in your home environment and sort of having to assimilate and get all your ducks in a row in this new setting. So I think, we are able to interrupt the progression of an eating disorder by getting in there earlier and provide a much softer landing for people when they leave. And then for some people who are getting our care, they just don't have to go back and forth. So I think that people being able to learn these behaviors in their home, do it in their home, be super involved with their family if it's appropriate, do a lot of exposure therapy in their own community. We're finding that our outcomes are actually, I hate to say it, but some of our outcomes we've seen are actually superior to some of the brick and mortar programs. And we have patients that have very high EDEQ scores upon admission. We work with very, very compromised patients at times. So I think that by there's a lot of benefits to that. But it's not right for everybody. We refer people to higher levels of care, not infrequently. I mean, we certainly try not to. We try to admit people who we think will do well, but sometimes we work with people who just refuse to go to a higher. They just are like, I'm not doing that again. More and more people have been having some traumatic experiences in brick and mortar at times too. But I think that what we see is when people, despite our efforts and the intensity of services, the high frequency of therapy, the multidisciplinary team, the care partner, the food specialist, when somebody just isn't able to change their behavior within the milieu of their home for whatever reason, that's when we realize that they may need to be in a different environment in order to heal. So we do refer people into brick and mortars when we see that happening. I also will say that people shouldn't assume that certain behaviors can't be managed in our program, because some of the patients that I've admitted that I've thought, I don't know if they're going to be able to manage this exercise compulsivity or the purging or whatever. Some of them really, really actually can do it. I applaud our patients. They show up every day. It's really easy to not show up to a remote program. All you have to do is not log in. It's really easy to leave. All you have to do is not log in. We have lengths of stay that are in the 70 to 80 day range. And that's because our patients are coming, they're putting their energy into it. They're creating bonds with each other and with our loving staff, and sticking it out and doing the hard work. So yeah, I hope that answered the question.
I think it did, and we are at time. So thank you to all of our attendees. Dr. Pyatt, thank you so much for your time and all of this amazing information. For those of you that will be joining us tomorrow, I look forward to seeing you then, and I will see you in the next session. Thank
Bye,
you. Have a
everybody.
good day.
Take care.
Bye.
Bye.